lot of symptoms that mimic the flu or various GI things. Remember, the valve it has a muscular mechanism, but it's kind of weak. It's not real strong. So it's under neurological control. It's also under humoral control. Cholecystokinin and things like that have an effect on the valve tone. And then, of course, as much as anything, it's a mechanical. It's basically a one-way flat valve, like the valves in our veins and channels. So it's a boundary. It's like we got these boundaries in our digestive tract, starting with the cardiac sphincter, pyloric sphincter. You got the sphincter of Oddi. You've got the ileocecal valve, and then you've got the valve of Houston, which is sort of a valve way down by the sigmoid cord. And so it's how the body compartmentalizes the digestive, different zones of digestion, so that the food hangs out long enough to get its proper breakdown. So I've seen these come in acute, where I've seen these, and this is a classic. People will come in and you'll think they have a hot disc. They'll act just like a hot herniated disc. And I probably early in practice, before I understood all this, I probably sent people off to the urologist, looking for an MRI, but they actually had ICV. Now I can differentiate, but anyway, so they will sometimes have the same kind of symptoms that maybe appendicitis, maybe, and of course the appendix is right there, just a little bit right there. So there's no trauma, there's no, it just comes on and but more often than not, it's more of a chronic kind of ickiness that the ileocecal valve. And people tend to be kind of sniffly, and sinusy, because when the gut's kind of goopy, then the sinuses get goopy. This is where we TL. It's also called Bernie's point. It's really tender with when you have appendicitis. If someone's got a history of appendicitis and they've had their appendix removed, they've got ICV, I guarantee. Or that's something you want to check on. They also have IRT, which we'll learn about. It's an injury pattern that gets set up. People who, one of the most common IRT things I find are past appendicitis. Either some people maybe had their appendix removed or not, but they've had a history of appendicitis. These are all the reflexes for open. Remember, now what's a little confusing, C3 lamina will be tender along with the right bicipital groove, along with the area right over the ASIS, and along with these acupuncture points, usually kidney 4 on the right and bladder 58 on the left. What we found with several people that were doing this, we had bladder 58 on both, and then kidney 4 on both sides. We had any of these could be possible, but for the test, kidney 4 and bladder 58 for the open ileocecal. Remember that. And more often than not, kidney 4 on the right, bladder 58 on the left. With closed ICV, bladder 58 bilateral. Remember that. That could be a problem. Maybe. So the nutrition is going to be stuff that is going to counteract dysbiosis. Basically, SIBO, which has been trending now for years, is ileocecal valve is chronically open ileocecal valve is going to lead to SIBO. So the other things associated, the iliacus muscle, which a lot of you had on the right, will often be weak with an open ileocecal valve. You want to look at anything that has to do with tone. Open ileocecal valve would suggest a lack of tone, overall tone in the gut. A closed closed ileocecal valve could indicate a lack of parasympathetic. It could be like a too much tone. Honestly, a lot of times you want to check. We'll get into stomach hiatal issues and whatnot, but a lot of times fixing the stomach. If you got a chronic ICV, fixing the stomach a lot of times will over a period of time. Another thing, I've had ICV, chronic ICV problems go away when I finally get people to chew their food. It's amazing how I'll always ask them, or do you chew your food? Oh, I'm terrible. I always eat really fast. So that's one place to start. It's kind of low tech, but anyway, regurgitation, not good. But by most modern calculations, around 40 trillion microorganisms live in and on us. We have about 30 trillion cells, so we're literally a host for these microorganisms. We're a vehicle for them, as much as the other way around. So the microbiome environment is very complex, and ICV open will cause an imbalance in where these bacteria go. And the bacteria don't get along. The different colonies don't get along. They have to stay in their own hood, or there's trouble. And that's why we have those boundaries. There's distinctness throughout the gut. Okay, so closed ICV tends to be too much tone, sympathetic drive, and you want calming things. Calcium lactate is a classic, also magnesium. On your chest, think calcium lactate. Calcium for closed ICV, just to kind of keep. There's other things too, obviously, but the classic AK correlation. Where open ICV, you want to think chlorophyll and digestive enzymes and things that will help bring up tone. Like we have adrenal desiccator, but any kind of adrenal, maybe thyroid, needs to be looked at. But overall, the endocrine system is just kind of key. Where with closed, here's your classic closed, from my experience in practice. Classic closed is a guy probably around my age with a tight, bloated belly and acute low back pain. And they'll come in, literally, I've seen them, they come in and they're kind of dragging this leg because this iliacus is so weak. And you go in and they think they got a disc out or any number of things. And a lot of times they have a closed ICV. And the first place that I'll go, because a lot of times they're so tight, pushed out here, I can't really find anything in there. I can't really get in there. So I go down to bladder 58 and it will send them off. Just tapping. So that's where I start. And I try to get them breathing. I try to do whatever I can to get their body out of sympathetic drive and into sort of a balanced state towards parasympathetic. That's your classic. I mean, you can see it in any age group, but the classic closed ICV is kind of the older guy with the really bloated, tight belly and the acute low back. The Chapman reflex for open, of course, is the bicipital groove, right side. And a lot of times, saying the other day, the patient will come in with shoulder problems. And you start looking at their shoulder problem is just part of what's going on. And it might be part of it. Mike McCall, my dear friend, many years, he was an intern in my office in 2000. He was in his last year of chiropractic college. And the first day he was shadowing me, we had a new patient come in. This guy probably in his 30s maybe. And he had an acute shoulder issue. I mean, hot shoulder bursitis. And I was kind of doing this stuff, and I went down, I checked his ICV, and his ICV was really hot. So I was having to, move his shoulder. And so I went in on the ICV, and I pushed in and up. And of course, it was pretty uncomfortable. I said, now move your shoulder, and he just goes like that. And Mike's eyes got that big, he couldn't believe it. And he wasn't into AK at that point. He had been exposed to it a little bit. But within a couple of days, he signed up for the next version course that was being used. So So we're good friends to this day. He's taught down here, but Mike, that was Mike's aha moment. I feel privileged that I was part of it. But that guy was, and we fixed his shoulder. I cleared his ICV. We did some adjusting, and did some percussion on his shoulder. And his shoulder was, I think I saw him one more time after his shoulder was fine. That was the problem. So you'll see that. Don't think it's just a shoulder. Who was it yesterday? Gallbladder. You, yeah. And it was affecting your knee, which you had treated, I'm sure. So, anyway, so where this in the ground, but this. They don't teach this in chiropractic, and they probably don't teach it here. Maybe they do. I don't know, but nobody. I tell colleagues of mine that aren't into AK, and they don't know what the hell I'm talking about. Medical doctor people, they don't know. They don't have no idea that this is a thing. It's a big thing. What causes it? You name it. Dr. Walker says diet, allergies, parasites, emotions, structural faults. One of the reasons it will mimic a disc, especially open, is it turns off an iliacus. So the iliacus and what muscle are direct antagonists? I'm sorry. They're well, they're antagonistic in one sense, and they're synergistic as well. Piriformis. So piriformis is external rotator. Iliacus is an external rotator. Piriformis is also an extender. Iliacus is a flexor. So if you have a weak iliacus, you might end up with a hypertonic. What does that do? Creates piriformis syndrome. Sciatic nerve literally lies underneath, and in some people, through part of the fascial part of the piriformis. So a hypertonic piriformis creates ischemia in the sciatic nerve. It'll act just like a hot nerve root, this bulge. And sometimes they have both. But if you get an ICV, a hot ICV, and somebody comes in and you can fix it and get rid of their disc pain, you're going to get all their cousins and their coworkers. If you don't fix their ICV and you don't fix their low back pain, you probably won't see it. So look at the diet. It often comes back to the diet. The big triggers are things that are abrasive to the gut lining, things that get stuck in that little valve. Those popcorn husks that get stuck on your back of your tonsil. You ever had one of those get stuck like a helmet on the end of your tonsil? Or those little things that cut your mouth when you're eating popcorn. Same thing happens down below. So if people are having chronic ICV, get them off all that snacky, cracky crap. Stimulants, things that they have lots of tough cellulose. Of course, alcohol and caffeine, but also if they have an underlying food intolerance, if they're badly gliad in their gut all the time. Corn sensitive. That's where it's great to screen for the primary. I only screen for about 6 food. Gliadin, zine for corn. I screen for lactose, which is the protein. Casein, solanine, soy. That's about all I ever test for. Because that's what everybody eats. Common symptoms: anything. Shoulder pain, sudden low back pain. It'll mimic angina. Makes people really lymphatically kind of congested and sluggish and just kind of sore all over and stiff. The classic dark circles under the eyes. They'll have intermittent, sometimes they'll have constipation and then intermittent diarrhea. Typically with ICV stuck open, you're going to have a lot of liquid, not being, the thing is when the chyme leaves the small intestine, it's very, very liquid. It's not until it goes into the colon that it pulls the water out and a lot of the toxins. And of course, the upper part of the colon, or the proximal part of the colon, has a lot to do with detox. It's pulling toxins out of the concentrating fecal matter and sending it right straight back to the liver. So if your colon is having trouble, getting rid of toxins, your liver is going to be over. That dark circle under the eye thing, there's a problem. Somebody comes in with dark circle, they got problems. They got food allergies, they got ICD, their gut is right. Pseudo-sinus infection. I'd say real hypothyroidism. A lot of times they're also not digesting their food properly up north, so the food is turning into toxic waste by the time it gets. So sciatica is the biggie. Watch out for that. Roughage, same thing. A lot of times just lack of tone. Can you imagine, I know, fortunately, I commute about 15 minutes each way to my office, but can you imagine commuting an hour, 2 hours each way every day? Just sitting in the park. And then you get to work and you sit in the cubicle for 6-8 hours. I mean, how can that be good? Things just don't move. Gravity is just pushing all this fluid down. So we tested some abs a little bit in session 1. I test abs all the time. It's super important to make sure patients abs. And most of the time they aren't. You'll find weak abs are just better than weak. So anyway, this is how we do it. Therapy like a localized over valve, test a strong muscle for weakening. Now, several times we were using iliacus. You're starting with a weak muscle. That's great too. Iliacus can strengthen. If they're kind of hot and acute sore, you don't want to be yanking on that. A lot of times when they have one of these ICD things, their low back and pelvic area is really tender. So the direction, 2 ways you can go: up towards the opposite shoulder or down towards the lateral hip. So you push up here, and if it re-strengthens, that's the valve that needs to be closed. You press down this way, and it re-strengthens. That's a closed valve that needs to be open. There's 2 ways you can do it. You can just go in and just milk it yourself and then treat the points, which I do mostly on patients. And then, or you can have the patient hold it up while we're doing it here, and then while you work, and then recheck it. Patients sometimes really like that. They like being part of the process. And I will show them how to reset it at home. Say every morning when you first wake up, bring your knees up while you're still in bed and go in and just kind of reach down and just give that a few passes up. See it, and it can really help in between. Yes.
I have a question on the ICV. Just because we do have acupuncture training here, or would it be beneficial to needle those points while we're doing it? Or like
certainly. Oh yeah, the bladder 58 and,
yeah,
oh yeah, absolutely. Yeah. I don't have needling within my scope of practice.
Yeah.
So I use a laser. I've actually brought that laser. And laser I use. I'll tap the point. I'll hold it. Whatever I'm in the mood to do. So I'll stimulate it. And those points, of course, will therapy localize, and the Chapman will therapy localize. But yeah, that's you've got an expanded tool. So, yeah. Dr. Goodhart came up with the bladder 58 because they're both low points, and somehow they balance the energy that helps the it was all explained to me at one time.
Opens the flow sheet.
It normalizes the flow sheet.
Yeah, between different
Right, the low points do, but his whole, there was a whole kind of logical progression the way to teach it. But yeah, it's the low points, of course, open the gates. But they were. I mean, we had a couple people here. That's all we did. So the two vertebrae you want to look out for, and this is for your test. C5, L1, C5, and then L1, 11. Or C3, L3, C3, and 11, L3 closed. The cranial faults associated with closed is universal fault, which we haven't learned yet. The cranial fault associated with the open is a zygomatic fault, which we that's so open valve iliacus, obliques, sometimes the rectus will be weak, all kinds of stuff can be weak, but the classic is the open. With the closed, there's the muscles. For the closed, the quads tend to be weak with the blood closed. Sometimes they're hypertonic, but they're usually both quads and the abdominals. Universal fault, which is a cranial fault where we're kind of moving the occiput relative to the parietal bones. We'll cover that in maybe next couple sessions. C3, L3, remember that. There's bladder 58. The Chapman points for closed are the same as the small intestine, right along the rib cage. They're not points, they're zones, Chapman zones. Valley Houston, it's, see if we get a better picture over here. It's basically, it's a less elaborate valve by far than the ICV. It's more of a muscular ring, sort of extensions of the house drum. And I had this conversation once with somebody I knew that was into this, and we were talking about valves of Houston. And I said, where'd they get that name? You mean, you're talking about haustral valves? Because there's also a term haustral valve, which refers to the haustra, the muscular, acting as a valve in signaling. And I looked it up a long time ago, and there was a Dr. Houston who came up with it. So that's what it is, the valve of Houston, which involves the haustra. Anyway, that's it's kind of, you know, it's where the contents come around. They got a pretty good turn here. They go way back in here, and where it comes around here, things tend to get all banged, locked up, and that's where the valve is. So the way you test for that, it's not as you just kind of go in and you TL it, and if it TLs, you do the same. And it might not be a specific direction. You have to kind of move. Maybe we'll find something with it. You kind of have to do more of a visceral kind of approach, move it until you get, you know, a re-strengthening, and then you just kind of do this one manipulation. Yeah, I can show that. Who in here has done visceral work? So some of you have. Where have you learned it? Was it what particular style? Moreau style or super valuable. I love visceral work. The longer I am in practice, the more very rewarding. Patients love it. It's be really fun. Anyway, lymphatic system. The reason that you guys know with the lymphatic system, you know all the stuff, right? Picks up the plasma that the veins can't pick up. It also picks up all the crud that the veins don't want to deal with. Goes in the lymphatic system. There's far more lymph vessels than there are veins and arteries. Just small. And for the most part, they have virtually no muscular wall. They rely on the muscle and pumping actions around them, largely like the bays do. That and their one-way valves, which you guys know all that. The reason we learned the Peck minor, because it is particularly relevant to lymphatic drainage. So I want to demonstrate very simple techniques called retrograde. And we use the Peck minor as a sort of monitor and as a treatment. Usually it's what we're treated with. Does anyone feel kind of puffy or sluggish or and we've all experienced that, right? Where you just feel like. So, feel sluggish. Your ankles ever swell? Feet swell? So, let's have you, Lynn. Now, I'm going to try first with her PMCs, her bilateral PMC. Now, if those were weak, what would I ever do?
Make sure they're.
Is it temporal bulge?
I can't hear anything.
Is it temporal bulge for the PMC?
Might be. How would I know?
Breath
Half
Half.
breath in. So if we came up here, like, oh, let's see. Ooh, I'd go half breath in. And then that was it. I need to correct that. So, so that's my baseline. Now, she's young and spry, so I'm going to have you lift yourself up in like a reverse plank, kind of a bridge, half bridge. Yeah. Now hold that there and let it sit a little bit. Let it relax again. That isn't showing. Let's test your Peck minor. Now remember, most of the lymph, most of the lymph dumps in what side of the body?
left.
Left. It dumps in the venous system on the left side. The head and neck dumps into the right side. Let's try that again. So what I'm doing is I'm trying to create a retrograde flow. You can also, probably the best way to do it would be to prop the table up like that and let her lay there, but I'm not going to do that. So try that again. Baseline, strong, good. Breathe. Yeah, so it does go. That relax again. So then I go to the Peck minor, and we did find that was weak, and that one's kind of weak too. So 2 fingers. The Chapman is right at just above the xiphoid. 2 real xiphoid. So if it's really active, it will. Yeah, it'll turn on. Okay, now do the same thing with this side because both of them are. Yeah, so that's active. So I'm going to treat, now if I was in my office, I'd grab my professor with the round, soft head on it, and I would just put it on low, and I'd just sit right there. Just breathe normally. So this is how we treated Chapman before. Kind of like O and I, only bigger circles. Now, anything that you find that would involve or somehow affect lymph drainage, like ICD, any kind of gut congestion, this might be something to make sure you check. Just hang out there a little bit. So right now, that's better. Let's see if we got the PEC. Now, if the PEC minors are still weak, then I need to fix it. So I come in this way. I kind of get underneath the, get the shoulder relaxed. I get underneath the pec major clavicular kernel. Then I get right into that. Sorry. And I'll do like a fold and hold thing where I get the muscle to shorten. And just, is that okay? And then you hold that and then you bring the arm out. You do kind of a fascial flush slash. This is like a myofascial release technique. Some people call pin and stretch. Pinning the fascia and then dragging the muscle under. It's not comfortable. It's not fun. Better, but it's still. Back to here again. See, I didn't get here. Lift your head and just let your body just relax everything. Now I'm going to do it in a little bit of a straight counter straight position. So then. There we go. That's way better. Give that a little stretch. Remember that pec minor only attaches to the cord blade. It doesn't attach to the humerus like the other. So that's basically it. That's the retrograde lymphatic technique. Talks about how food gets digested, gets sluggish. Amazing how much stuff is also transported from the gut by the lacteals. A lot of the fats that we absorb through the gut are picked up by lacteals, the lymphatic system, instead of the venous system. So tone, abdominal tone, movement. Most of our patients need a lot more movement. Even if they're doing a lot of movement, a lot of times they're doing movement that's repetitive and actually overdoing a lot of things. Diaphragm is super important. It's the main pump of chi in the body. It also has a profound effect on the lymphatic drainage, especially from the lower half of the body. I'm going to show you one more. Here's the, see that? This is the pec minor. It's a really good picture of the pec. Someone else come up here, please. I want to, these are all symptoms that can be sluggish. There's the technique. Dr. Francis always said, look at a base posterior sacrum. We didn't check that on it. Then I want someone else to come up. I want to show you something that isn't in part of our curriculum, but something I use that's really good. So somebody suggest to me how I would determine where her occiput is, where her sacrum is. What, give me one tool. Ocular lock. Right, ocular lock. So I'm going to do ocular lock. Her eyes go straight up. That's good. That would be inferior occiput. Her eyes drop straight down. That could indicate base posterior sacrum. So, did you have any sacrums? Did you have sacral wobble? So, we won't fix that right now. That could be, yeah, something. Right. Remember to fix that if there's something in there. Someone else come. Yeah. So there's this very interesting there's this structure of this reservoir, which is part of the tank system, called the cisterna chyli. Remember that from anatomy, right? And you know where it sits? It's at the very back of the body wall. It's way back, tucked in, right up next to the back of the diaphragm. So it relies upon intra-abdominal pressure, pumping up pressure changes, and which is created by the diaphragm and the abdominal muscles. It relies upon that pumping action to move that limb. So all of the lymph from here to here drains into that cisterna chyli, like a big it's a reservoir, basically. Now, the way you access it is it's right about here, but you're pushing through just about all of their innards to get. So you have to sort of think about the fact that you're just increasing pressure against all of their organs equally, and then ultimately into that. Now, I don't test for it. I mean, you could test for it, but it's off the heat. I don't really test for it. If they have, I mean, a lot of my patients, I know their lymphatics are sluggish. Things are puffy, their faces, everything's kind of puffy, so that I know they need it. With those folks, I bring the knees up. I'm going to get on, this is a technique I learned a long time ago. I get on this area here, right over their solar plexus. I can breathe in, then breathe out. Now try to breathe in through your nose. So that activates more diaphragmatic. I'm kind of riding it down. You okay? Breathe in again. And you can feel that diaphragm pressure coming up your head. Now about every 3 or 4, there we go. Good job. About every 3 or 4, then I'll come over here and I'll go over the spleen area, and I'll give that about 2 or 3 pumps. Make sure it's not getting too much blood pushed over into it. And breathe in. And out. Now I'll hold there, go ahead and breathe in. I'll feel a little bit of pressure, and then I'll let. Once again, holding, breathe in, and just as I feel the pressure build under my finger, breathe in. Right there. Then I'll do that about 3 times. Once you get in there, breathe in. Good. And then I'll give this another time. Very calm. Okay? Yeah. Sometimes people get a little dizzy. It will lower blood pressure. So be careful if they're kind of older, prone to that kind of thing. If you get them up too quick, they might get a little loose. Because you're right over, you're affecting their knee. So the body is going to adjust. It's going to lower blood pressure when there's pressure. So just like putting, pressure on your carotid. Anyway, that's called. Gosh, what do they call that? Cisterna chyli technique. I learned it from Dr. Davis years ago. I took his visceral work, and he has some great moves. He's still around. He's in. Right lymphatic duct, which mainly drains the head and neck on the right. If you test, the way to ferret that out is you have the patient flex their neck and their chin, like so, and then you test a strong. You try it on somebody. I don't use this too often, but this time of year, you get, especially in our area, everybody's getting over blues and goo. Somebody with you got a Olympic, didn't you? Yeah, honest to God, Lynn, the feet, ankle muscles weak. Somebody else did it too. No, you had it right. Okay, so we'll look for, let's try lats. Let's try this one. Okay, that's what we're doing. It's also related to this. So go ahead and flex your neck and then draw your, like you're gonna put your chin in your sternum notch. So that shows, now could that be other stuff? Of course, you might have something going on with this neck. That does show. Now, if we check your pec minor, it's weak. So from those two bits of information, I can sort of assume that, I know we don't want his pec minor to be weak. We don't want him to weaken when he flexes his neck, so we'll do this treatment and then we'll see if it clears it. And right about in here, just underneath there, is where that right lymphatic duct steps into the vein. Couldn't breathe in. Now, I don't mean to pick on you, but now watch when he breathes in. Look at right here. Breathe in. Not bad. I mean, this lifts up. This should sort of do this. Actually, let's do this. So now go ahead and breathe in. So he could be doing a little more of this when he breathes in. Most of us could. So we tend to get locked this way where you breathe in. So you go up just so far and then the shoulders come up. I'm exaggerating. But what we want is we want the sternum to kind of lift up and out, and we're hinging right here at this thoracic hinge. And so normally, under ideal circumstances, our shoulders actually open up this way on me. And that facilitates all these muscles back. Hold your breath deep. Now, keep that. Yeah, so hit right then and there. Like on this visit with this patient today, I would be giving him postural exercises to work with. Breathe in deep. And I'll put him in this position so he can kind of feel what that movement feels like. And then I'll have you try to bring your shoulder down towards this point, both sides. There you go there, and then the other side. So we can start to feel these muscles. Then I'll have them stand up against the wall and put their body against the wall. And it seems so simple, but a lot of times they can do this, but they can't do this. And what they're going for is this. And then once that feels a little easy, then they start doing this, what they call wall angels, right? Trainers call them. So that would help take pressure. And all of us are prone to this because we drive and we sit too much. So now just kind of now try this again. Flex and yeah. So that moved enough length that it kind of cleared the issue. That exercise is amazing. It's so simple that people are locked too much this way. So something as simple as, and you can give that to anybody, somebody 90 years old. Make sure they don't think they have to touch their arms, because a lot of times they can't. Get as much of you touching the wall as you can. Just don't worry about it. Just every day you'll get a little bit more. You can get more surface of you touching the wall. Anyway, that's for the right duct. We did DTRs. Any questions on DTRs? Maybe when you're doing your AK club or something, play with it. But DTRs are, you know how to do a reflex. You've got a reflex now, and so you know how to test a hamstring and a quad. So just play with it. It works the same way. You can do bicep and tricep. We didn't show that. Yeah, Dr. Goodhart was big on. I remember when Valley came out with it. Dr. Goodhart was really big on L3 and C3. It was his latest thing. Anyway, I would like to. We had this slide up earlier today. I would like to maybe next session or two. I'll bring I have the Leibowitz test kits. And does anybody here have those? Have them? Okay. Maybe I could get you to bring them. Yeah, well, I don't want to do this weekend, but maybe next time. That way I won't have to bring mine on the plane. I like to travel light. So these are the things, once again, earlier today, this is the stuff that you either know or you've been exposed to so far in the last few months. And these are the things you need to understand, at least the basics about tests, which is many, many months away. But also the muscles. You need to know the muscle Chapman points. You need to know the muscle. You need to know the muscle innervation, Chapman reflex, related organ and or gland, and related meridian. Now we're going to learn a lot more about the meridians and how to use that system. But for right now, every muscle has a meridian and a gland or organ relationship. Oh, you weren't asking a question. Scratch. Any question on these again before I leave this slide? Nothing? There's a lot there. So everybody feels comfortable with ICD. Everybody feels comfortable with fixations, somewhat. You kind of get the general idea. A couple of you had a limbic fixation. Those are really cool. I don't know why. When I find them, I just get a kick out of them, and I find them often. Never seems to get old. Same with the fixations. Somebody's got a bilateral psoas and their occiput is like, you fix that and it turns on. It's like, yeah, that's amazing. I would like to go over. I'd like to kind of maybe go over all the muscles and maybe look at some fun. Some of you you're all testing great, but some of you're all testing good. Some of you could test. I would like to. Some of you, I want to make sure you've got the hand and arm position down. So I would like to run through all of the muscles if we could this last hour or two. Does that sound fruitful? We could. We could. And then if you would like, I would also like to maybe I can use Dr. Whitney or somebody and just go through the protocols, Cat 1, Cat 2, some of those big ticket items. Challenge.
Can we do the cranials too?
Cranials, yes.
We didn't get to actually do the last ones. Like we just did like a quick.
That's right. Last session. Okay. That's a great idea. I think you all have cranials. If you don't, you probably do mine. Last time I had all you guys, I did the cruciate on those of you who were here last time. So was that helpful? I don't want to have to do that with this, all of them, but you get an idea of how much pressure and how fast you are, how slow you need to be. Yeah, let's workshop, because we didn't workshop the temporal bulge. Okay. So remember, with temporal bulge, start with their PMC. It's a good way to practice the bilateral PMC. If they're weak, half breathing, and And that'll be a cranial, that'll be a temporal molar. If half breath in, they're still weak, full breath in, they're still weak, all breath out, they're still weak, you got something else going on. Yeah, let's do the cranials first. Let's do the cranials. Actually, no. Let's do this first, and then we'll do the cranials. Somebody that doesn't mind being muscle tested themselves, probably be like a muscle testee. Okay, I'm just going to run through them kind of quick. Okay, and I'm going to make.
Yeah.
Maybe. So, so I'm going to do this. This won't be on your test, but this is a cheap way to look for switching. So right now, she's your little switch. Yeah, that's switching. So close your right hand. Eyes open. Ocular lock. So she weakens eyes to the right. What is that? C2 on the right. Probably. And so we need to make sure. So does that negate the switching? So here she weakens without any eye movement. And that negates it. So that's going to be, that's a quick and handy way to clear at least the most obvious layer of switching that she's got. So right there, you can adjust it today. Did I adjust your neck? Something else. I adjusted
Like
your
I
lid
had
neck.
a, yeah.
Just going to do a little challenge on her C2. And I'm going to have you breathe in. So pretty straightforward. So, okay. I'm going to do a respiratory correction on your C2. Always nice when you can. That clear. That's good. We can proceed. Okay, so I'm going to start right here. Session 1. Head forward, turn, hold. I stabilize her and I push back. Scalenes as a group on the right. Right there. Scalenes as a group on the left. Head full flexion, full contralobe rotation. I stabilize her here, pulling back this way. SCM on the right. SCM on the left. A more classic way would be around in front and all the way forward. This is really good if you've got a really big. See my vector? So Lindy Tupman might find it better that way than this one. This is a pretty good screen. Those are the neck flexors. Sit on. And then neck extensors learned yesterday. So as a group, strong. Now, if that was weak, we'd consider maybe lumbar fixation, according to our fixation. So, hold. And those are good. Now, if those were weak on both sides, that would be sacral. Now, if she was just weak on one side, that would be lumbosacral on that fixation. Now, face that way. Upper trapezius, shoulder up. Put your hand on their shoulder first. Have them bend their head over, turn slightly away. Hold. That's the test here. If you were weak, it would be side shoulder up. It's a simple thing, but it's so much easier than if you have them go into that position and then you try to fish your hand in. It's like one of those little things that can make a big difference. Put your hand in first, they lift up against your shoulder, and you're right there. That's the upper trap. Now we've got deltoid as a group, middle, we've got posterior, we've got anterior. The patient's arm sets your vector. That's the vector for anterior. This is the vector for this is the vector for deltoid. What am I testing? What's this side? You're better. Oh, that's right.
Oh, good job.
Yeah. So what is it? What am I testing?
Scaling.
Huh?
That's what I meant to say. That was the word that was supposed to come out of
Sort
my
of
mouth.
an S.
I was serratus antimus, as they say in the old anatomy books. I think like the old Gray's Anatomy, serratus antimus. Three divisions. This muscle, get good at this muscle. It's really, really handy. It tells you a lot. So, fix the okay, so this is last session. Bringing and retracting the scapula. I'm getting a hold of elbow, stabilizing here. I'm also sensing any movement that may happen with the scapula. And she's looking away just a little bit. Hold. What am I testing?
Rhomboid.
Rhomboid. Good. That's a good one. Rhomboid. Now, if I thought rhomboid was hypertonic and needed vaginal flush, what would I do? I test it and it goes, well, test strong and clear, but maybe the pec was weak. Make sure that you give her a good stretch and you can feel that rhomboid moving. Still holds that. If it's weakened, then that's a vaginal flush. Yes. Middle trap. We did upper trap. Here's middle trap. Here's lower trap. Fibers run this way. That's why it's lower. The arm is upper, but the trap you're testing is lower. And that's your good shape. Did you? Good for you. Yeah, I did too. Yeah, I had a couple of ADHS. So middle and lower trap, right? So what's the lower trap bilateral weakness related to? What part of the spine? What kind of fixation? Thoracic lumbar. Thank you. Okay, so while we've got you seated, we can also do the teres major. Coming through like this. Hold. A little lackluster. Not bad, but now you could also test that prone. So that would indicate bilateral weakness could indicate thoracic fixation. Chase down. Okay, so sit facing the, actually face this way. Face the trap. Together. And now you can all see I've got her turned about 15 to 20. I'm coming straight in this way. What am I testing?
Rectus abdominis.
Rectus abdominis. And if it was weak, what might I try? What would be my go-to? I have two people like that.
Glue.
Sagittal suture. And I could even see if her sagittal suture is jammed, just to be on me. It's not.
Here's what I found.
Oh, shut up. It's something about cranial sacrum. She was looking at something about cranial sacrum. Sorry, Sarah. I'm always nice to Sarah.
Don't talk to her like that.
Who knows in the future?
Yeah.
When AI takes over, I don't want to be on the bad list, you know.
Naughty list.
Be polite to AI. Okay, where were we? Oh, abdominals. Okay, we're gonna learn more abdominals. But when you're playing around with abdominals, they're so important. So that's the rectus abdominis. Now, if you have the patient lordose a little bit more, then you're getting a different part of the rectus. So you can ferret out issues with it that maybe aren't obvious when they're in. Bring them over this way. Now I'm going to be inducing left rotation, and that tests the obliques as kind of a group. Which she's trying really hard. And she's strong, but now see, that's really good. That's really dialed in. This side here. Now remember the obliques, external, internal. So when I turn this way, it's my my right internal and my left external. Yeah. Anyway, so we'll learn those going forward. I think that's lay on your back. We'll do all the muscles that I would do with a patient supine. Now, hands to your body, or hands to your side, off your body. Somewhere, put your hands somewhere. Now, push down. Okay, so that's weak in the clip, that's a glute knee. And that's weak in the clip. So, something going on with that. Are these ulcers?
No. Reba.
Oh, yeah. Shake one. Okay, so this gluteus medius, that's the cheek test. Here's the cheek glute max test. That's pretty good, really good, actually. Now, tell me what I'm testing. So what? Okay, so that's psoas, and what am I testing here?
Iliac disc.
Okay, and what am I testing here?
Piriformis.
Or two piriformis and rectus.
Oh, I thought you were twisting it.
Yeah. Okay, here it is. Piriformis, right? Very similar. I mean, you can test them really quick right there together. Now that one is a little mushy. Yeah. And that one's a little spicy. But okay, so rectus. Okay, so tell me what I'm testing now.
Quads as a whole.
Quads as a group. Okay, now am I testing more medial and more lateral? Yes, I am. This will kind of target this will target the lateral rectus, medial rectus. Now what am I testing? Now what am I testing?
Hamstring.
Hamstrings. Now what am I testing? Huh?
Lateral,
No.
lateral hamstring.
Medial hamstring. So I'm kind of rotating this in. The idea is I'm emphasizing more medial hamstring. My vector changes from here to here for medial hamstring. Then I externally rotate her tibia. Now I'm asking these to be emphasized. I use this arm. So both of them are good. They're good as a group. They're good individually. Now, what am I testing? Pop legs. Very good. Now, must be both. You eat both sides. That one's here. Now, what am I testing? The cheek test.
Adductors.
Adductors as a group. Very good.
Sartorius.
Sartorius. Everyone agree with that? What's the sartorius do?
Adduct and
Adducts, and it also, it kind of externally rotates and flexes, it helps flex the knee. But more than anything, the sartorius and the gracilis, which is this one here, right? Internal rotation, get down, my vectors here. It's good. The sartorius, think of the sartorius and gracilis as importantly used for proprioceptive feedback as for actual muscular activity. They're a tremendous sort of guy wire to keep the relationship between the knee and the pelvis, neurologically speaking. We haven't done gastro. Okay, so just to confuse you while we're here, I'll show you. This is how I test gastro. So here's hamstring. Put the foot into plantar flexion. Get real low. I'm right on the heel, and I'm pulling up this way. That's a good screen for gastroc. And of course, gastroc and hamstrings both work together. They're both flexors. They both cross the knee joint. That one's good. Now the hamstrings test fine. Emphasize that, and I get low with my vector. Fine, and that could be if I could go right in here and just spindle up and see if I'm on track. That muscle should spindle right up temporarily. And it does. So something going on with that. Psoas iliacus, rectus, TFL. Thank you. Tell me what I'm testing.
TFL.
TFL. They're both pretty good. What am I testing? PMC and PMS, right? And
Big minor.
pec minor. Okay. Now, what if screen for that doesn't do it? Doesn't okay. All right, well, we won't change actually. Okay, what's left? Glute max and prone piriformis. There's nothing left to supply now. You want some paper? No. Sure. You don't hear. So now, while we're here, I will get you. I need to have your arms move. Is this helpful? So from here, I can test the teres major. I can test the middle and lower trap with looking. This is really hard. They'll never fake that one. And then like so. Those are really good. And those were good to see the too. I can also test neck extensors in this position too. Like so, make sure you have a hand here so they let go. See, she's really pretty good. My vector. My arm is always really low. It's not this. It's always. Now, what am I testing from? Piriform. Sure? Quite sure? So that one's strong, this one not so much. Now, what am I testing from?
Hamstrings.
Hamstrings. Viral. So it's deceiving when the foot goes out, but you're testing the knee. Now what am I testing? Very good. Wow, that's a good one. Very nice. Okay. Very nice. Blue max. Right. Now, if those have both been weak, what would I think? Upper cervical. I think all of you said upper cervical. You're the only one. What's that?
That's because mine were out. That's the only reason why I did it.
There's your what?
Oh, that's the only reason why I did it because his was out.
Are you feeding him lines? I was in a practical years ago in chiropractic college, and my buddy, one of my buddies, classmates, we were paired up, and I was all nervous, and we got in there, and the instructor said, "Now, what are the stages that ice therapy goes through? What are the stages it goes through for ice treatment?" Well, everybody knows that, right? It's cabin, cold, achy, burning, numb. I'll never forget it now. But I'm like, cold, and then it kind of, I think it's achy, and then I just stumble around, and my buddy was sitting there mouthing, because the instructor, he was trying to feed me the line, but I didn't see him. I was looking down, trying to think, and I blew it. And afterwards, he goes, "I was trying to give you the line anyway." So that's all the muscles I want to go through. I think we've got them all that we've done so far. So let's do categories. I'll just walk through we'll go through category 1. Now, I have my patient already prone. I have a strong indicator muscle somewhere here. That's a good one. That's a really good one. So I will have her, now maybe I already checked her posture and I saw kind of a portion, maybe some AP sway. The structure's on the plumb line, but things kind of twisted around it. One hand. And hold. And look at that. Beautiful. Are you trying? Mm-hmm. Okay, good. So that's positive. Then we want to know why. We want to know which side is the lesion side, or the right. Everybody with me so far? Not this way if you're not sure. Okay, lesion side. Now, what does that tell us? Does that tell us that that's what we adjust, or what does it tell us? It tells us that we don't want to push into that, and we don't. And if there's a block under it, we don't want to push into it because we don't push into a block. If the block's over here, we still don't want to push into it because we don't want to push into the lesion side. That's what it tells us. That's why we want to know that. It also tells us that most likely there'll be first rib tenderness. Is that clear? No. Good. So they don't always have rib tenderness, but often there'll be first rib tenderness on the side, on the lesion side. So we know that's the lesion side. What do I do next? Find my holes.
Are you gonna do
I'm going to do a rebound challenge. Yeah. And I'm going to be on this PSIS and over this ischium, and I'm going to do a challenge like so. Test the strong indicator muscle, and I got lucky going this way. So which way do the blocks go? Opposite. You guys are good. I'm worrying less. My goal is that every single one of you pass the test. I mean, just bring it to its knees. Make it so they need a better test. That's my like they're going to have to rewrite the test. So now the blocks are there. Now, if she had first rib tenderness, I would monitor that. I could get overly thorough, and I could have you BTL, see if the blocks are negating that effect. Seem to be good there. So what I'm going to do now, I would monitor this if it was tender. It's probably not. I'm going to go down here to the sacrum, and I could put pressure here and kind of help speed up, and that's a good idea. And that's not into a block, and it's not on the involved side. But, and remember that for the test. But here's the way I think it works a lot better. Just to be brutally honest. Breathe in. Good. Now, see how my hand moves when she breathes in? I'm putting pressure, but as she breathes in, I take advantage of that natural rocking motion that happens with the breath in. Okay. Now it feels to me a little bit more stuck on the left, but I don't know. We'll see. It'll. There it goes. Yeah. Breathe it again. Good. 3 or 4 times usually, and then how do I know when the blocks are done?
Retest.
The hamstrings will both, Dr. Francis, he used to test them both at the same time. Very dramatic. That's still cooking, huh? Okay, so breathe in. There you go. The category 1 takes more patience than sometimes I want to indulge in. Breathe in. But it's so rewarding when you get a really good change with cat. Now, I have colleagues that use drop tables. That's still cooking. You're a tough customer.
You're testing all that, so.
You okay?
Yeah, it is.
Well, you were talking about having that. Unfortunately, cat 3 we don't do. Do you still think you have cat 3?
I don't know.
Let's see here. There we go. There we go. Let that sit, because I did just fiddle with it. So let that sit just a little bit more. Make sure I wasn't changing the parameters over there. That worked. Well, now, same time, possibly. Now we'll just double test. We use this indicator most of the time. That really did shift things. Go ahead and test. Still there. Still there. I didn't get it. This always happens when you don't want it to.
Never test this last.
So TL just the left side. I mean the right side. Sorry. So we got a cat 2 that we need to clear up. That's going to muddle up the. It's going to muddle up the. So since we're going to teach that next, review that next, lay back. That's what it appears. Yeah, makes sense. So now I'm shifting from category 1 to category 2. What's one of the main differences between category 1 and category 2?
Leaning. You're saying the way it looks?
Okay, so, yeah, I guess I didn't ask the question. I'm getting a lot of good answers, but I guess what I'm fishing for, I'm trying to see. Yeah, okay, so category 1, we treat properly. Now we'll test it anywhere, seated, standing, all over the place. But when we treat it prone. Category 2, we treat supine. Category 1 is a 2-handed TL. Category 2 is a 1-handed TL. You got all that down. Okay, so
what else do I look for? Now, the difference between what's going on with the pelvis, of course, I think you were starting to address that. In category 1, the pelvis is torquing. We're really treating torquing all the way up. With category 2, we're really treating one-sided, like a subluxation of the SI or a fixation of the SI. That's a key difference. But then when we know we have a positive TL, I look at the leg length, and her right leg looks short. So her right leg is short. So, and which was this was positive side. So if it's a short leg, what would that indicate?
Anterior. The hip.
TI.
I think you're switched.
You say if it's short.
Short. That's gonna.
Yeah.
She's consistent.
Yeah,
Yeah. So PI is make a short leg. So remember, UMS for the PI. Posterior inferior means that the PSIS goes posterior, and then what does that do with the pivot point of the hip? Brings it up that way relative to the other side. So I'm going to go to her upper fossa. That's positive. So upper fossa. M is medial knee tenderness. And short legs, we already established. So I'm happy with that. So what am I going to do now? I'm going to block. How am I going to block it? How am I going to block the PI side? I want to bring that PI, that P whatever is going back that way, I want to bring it towards me. Right? So there, it's propped up. This one goes under the ischium at an angle. Now, how do I know if I got the blocks right? I go back to my UMS. Clear that. Now, that may be less tender. It might take a little longer. And then it might not immediately change the leg length, but as things creep, you come down here and, yeah, so she's almost pretty even. Right? Real close. Okay. You keep somebody on Cat 2 blocks for a long time? Short time. Less is more. How about prone category 1? You can keep them quiet. Not much. What you'll know is when the hamstrings go weak, it's time to pull more. Because the blocks are now, they've gone beyond correction, and now they're creating aberrant stimuli. Now, if somebody's pretty cute and with a Cat 2, I'll let them lay there a little longer. And then I'm always going in here checking for ICD and different things. So I'll take my cursor a lot of times, I'll put it on the bottom of their foot, and that kind of speeds things up. Or we'll talk about, the recent trip to Hawaii or something. It could be cooked. That was quick. So he pulls the blocks out at the same time. So upper fossa. Show, is that less tender? And did her legs stay? Yeah, she's pretty neat and steep. Now they face down. I hope this is helpful. We're taking some good time. I mean, we're pretty good. We've got all the slides pretty much covered that I want in this section. So, but hopefully we can really cement some things. Now, this was our strong indicator. Two-handed TL, please. Actually, yeah, let's check first into that. See if we cleared that cat 2. So I'm happy with that. Now, two-handed TL. Came right back now. We're back. So now I'm going to have you go away. I'm going to challenge. Okay. Now they're going to go in. I was switching. Last time we blocked her the wrong way because that's what her body told me, but it wasn't really that sure. Because the Cat 2 was muddling up signaling.
So do you always take care of the cat 2 first then? You have like cat.
It really depends. I would say not always,
Oh.
but go ahead and TL. Any first for attenders this time? If I keep pushing, I'm going you know, I checked for both. So I would say probably the Cat 2. I mean, if I was pressed, I would probably clear the Cat 2 first. And it's not at all uncommon to find a Cat 2 and then a Cat 1 is revealed or vice versa. That's not at all uncommon. That's the value of using the muscle testing. You know if you got it or not. If you didn't, then your work's not done. So let's just see. Maybe that'll clear. Yeah. So let's try it again. And two-handed TL, please. And hope. Yeah. So that's nice and crisp. That's really good. I'm happy with that. Yeah. So Cat 1, Cat 2, and then Cat 1 again. We did. Now, you okay? So go back to this since you guys are good with this, right? We're gonna drill through as much as we can here, and then we'll try. I want you to do a prayer position over your statement. What's that? Sacral wall. What do I do next? Expiration. Very good. Why not expiration?
Or annoying.
You can also do seams.
I'll do both, right? But, yeah. So, okay, so we know we have a positive TL for sacral wall. Breathe in. Hold your breath. Gaze it. Breathe out. Doesn't begin. So we got inspiration. So if it's inspiration on sacral wall, where do I challenge? I challenge the sacrum and the nominate, but do I do both sides? Challenge both sides. Yeah. So like I go in here, and then I grab the front of her nominate, and I'm going to press like that. So I'm going to challenge, and then I'm going to test, and I got lucky. Or I could challenge over here. And that doesn't show. So my correction is going to be on this side. On what phase of respiration? Inspiration, because that's we determined with the negation of the TL. Those are good. Good. Just learned this yesterday. Okay, so I'm going to do the correction same way I did the challenge, about 4 or 5 times. Okay. With cranials, with pelvic respiratory moves, the 1 or 2 or 3 the first, second, third or so corrective moves you make, you're listening as much as you're correcting. You want to let your hands kind of feel for the rhythm that the body is there, not force the rhythm on the body. Just kind of feeling for the movement. And once you tune into that, then maybe a couple of 3 more moves. And you're kind of priming the pump. You're getting the nervous system to kind of revert back to what's a more ideal pattern of firing. So keep picking on this because it's so good. Prayer position. Good. So that seems to have cleared. So sacral wall. Now, while we're here, we're not going to workshop this now, but go ahead and put your hand on your sacrum. Okay, just lay it there. Now, if that weakened to the clear, I would think, well, there's something wrong with her sacrum. I'd start looking for maybe a sacral malposition or subluxation. But now, if she touches there and then tractions down, and it goes weak, that's an indication for phylum terminal, which we kind of ran through the slides yesterday. And with that, then I go here and I'm going to challenge this way and this way, and like it seems like both ways. And then I'm going to palpate for tenderness in the spinal muscles. Any of this tender? It's all the tender. So tell me like a really signature tight tender. Right. Here? Yeah. Here? Yeah. So that's kind of, is this work? Okay. So we'll go with the most tender. I'm going to monitor that. And I'm going to go here and I'm going to be pressing up in the challenge direction, which was pretty much just due north. And then I'm going to take her occiput and as much of for C1 as I can get, and I'm going to pull down as I pull up. Have you breathe in? There you go. I feel her sacrum. On exhale, it rocks back. On inhale, it rocks under. I'm just kind of riding along with it, but I'm keeping that steady pressure. The idea is I'm lifting phylum, lifting the coccyx and relieving tension in the phylum terminus. Now, is that any less tender? It is? Good. Tenderness here should lessen. That's your indicator. And then we'll retest it. Straight TL, nothing. But if you traction down, still nothing. So we got it. That's phylum terminal lift. That's like another little finishing piece you can do along with sacral wobble after you've done the big categories. Don't go straight to that. Yes, good. Yeah, a little bit. Stand up. So, yeah. Okay, so what am I testing?
Upper trap.
That. What am I testing here? Latissimus. Now, we just did these a little bit ago.
SCM.
Now, I'm going to have you step forward with your right foot and stop. Okay, so what should happen? What should happen with the upper trap? Which one should we do? Forward leg side. Whatever is the forward leg side, that upper trap should weaken. You start with that and then the rest kind of fall into place. Shoulder up. Yeah, it weakens like it should. Now, if we come back to neutral, he's rock solid. Now, another thing that should happen is this lat should inhibit, allow the arm to sweep forward. And the opposite SCM should weaken as well. So if the right leg is forward, right upper trap, left SCM, left lat, and right piriformis, which we can't really test in this position. Come back, left foot forward, and left upper trap. Beautiful. Right SCM, perfect, textbook, and the right lat. Everybody performing as expected. So that's gait testing. Remember that? Any questions on that? Remember that session 1, 2, session 2. Okay, testing the seated piriformis. There are 3 ways to test the piriformis, right? Supine, seated, prone. Probably other ways. You can test the standing. So you clear there. While we're here, you can TL bilaterally for Cat 1. Still hasn't come back. One hand, perfect. Other hand, perfect. Sacral wobble. Make sure we're leading. So we're good there. Go to sacrum and traction down. So we're good there. Okay. Now come forward about 30 degrees. Right it up. Big time. Should that weaken? Yes. Who said yes? Yes. You all said yes, right? That should weaken. Okay. So if we go back this way, march back about 15, about a decent way. That should weaken also. It shouldn't, however, weaken in the. That's called what? Anybody remember? It's an acronym. PLUS. The PLUS stands for piriformis, lat, upper trap, and SCM. And it's different than the gait. So if you go forward, upper trap, that upper trap should be in it. This SCM should be. And there's only one way these go. PLUS is that way. There's no like right or left. Okay. What does that do? Remember PLUS and gait. What does it help you ferret out? Use that term ferret. I never use that term. Just somehow ferret it out. It helps you pull out more hidden problems, especially where the dura attaches. So the gait test, if any of that failed, which none of it did, it all worked beautifully, we would have had our patient TL to the sacrum, to the SI, and then to the upper cervicals and the cranium. And we would have found something that was muddling up the works. Now, sphenobasalar, somebody had a sphenobasalar in it. You did, yeah. ICV, let's just run through ICV really quick. These guys, I think, have it. You'll be right for the test next month. Part of it. Wrong. ICV. Good. At least it's not showing. Go over here to valve of Houston. And a little bit lower and a little deeper. That valve of Houston's down in there pretty. There we go. Keep your knees up. Now, how do we treat valve of Houston? I go in and I'll kind of pull up this way. Usually, like a lot of times, any parts of the guts, they want to go up because their gravity's pulling them down. So I kind of start with that. So I push there, still strong. I push there until it weakens. I push there until it strengthens. So my vector is going to be the direction of strength. Breathe in. It's a static challenge. Breathe in. Now, am I on her valve of Houston? I'm not sure, but I'm kind of creating some pressure changes, and hopefully it'll kind of get things to spring back into normalcy. Breathe it again. More. Breathe in. So I'm going to have you breathe in. There we go. One of the funniest things I ever heard years ago was I had a patient who was really pissed at her mother-in-law. Sounded like a real character. And how her husband always jumps whenever she gets a fart caught sideways, my husband has to rush down there to help her. And I just cracked me up with this thing. That was 30 years ago. The idea of a fart caught sideways. Just cracks me up. Yeah. I don't tell patients they got a fart coming sideways, but sometimes I think it. You have a lot of gas. Okay, so in just we just did this, but retrograde, remember, over there, bilateral. Now, if those were weak, what would I do? What do I tell Dr. Whitney to do? If they are weak, have breath in, right? Which would indicate, and if it strengthened, that would indicate, temporal. And then retrograde, let it hang there for a little bit. Now, some folks can't do this, and if you really want to test them, prop your table up, bend some footstool or something, put on your table, and have them put them in pass it, hold there, and see that goes weak. So come back down. So you test the pec minors. They both seem to be. If they're both weak, go to the Chapman. And if that strengthens, treat the Chapman. Somebody else with a green shirt. So, Tiana? Which one's Tiana? Tiana, right. My new office manager's name is Tiana. One N or two? Oh, yeah, hers is one N. All you need is one, right? I was texting her and using two N's in her name, and after she was with me like a month, and I was here, and I saw her name spelled with one N. I said, she hadn't corrected me. She said, "That's fine." I answered both. So Chapman reflexes, you can be fairly vigorous with them and read your patient's reaction. Okay, good. So that saves me, hopefully, from having to really go into the muscles themselves. If they're a little bit, you good? So I would be good with that at that point. Okay, so you don't have a compaction. So let's pretend she had a compaction on this side. So let's see if we can. This is when you felt the body. So I'm going to. So what's happening? Every muscle's weak. Yes, it is. And it wasn't showing before, but I just did it. I just kind of compacted it. Now that one's strong. Yeah. Okay, we could, test. I mean, everything is going on, except for Terry's minor. So now, this one's kind of odd. Somebody else had this with yesterday. I want you to do like you're doing it. Fully contract that series. Terry's minor is related to what organ? What gland? Triple warmer meridian thyroid is has that 10. Yeah. So weekends after 10. So what did I just do? RMAE sub. And that's associated with what kind of injury? Compaction versus shear. Shearing is going to be the triad of strain spring. So I'm going to get right on the insertion. So when we're done here, we will do cratings. Be a good place to kind of feather out. So what muscles, you guys know the rotator cuff muscles, right? Teres minor,
Infraspinatus,
infraspinatus, supraspinatus, and subscapes. And then the muscle that tendon crosses literally right practically through rotator cuff.
A tendon that goes through them?
Literally right through it and anchors in the back.
A flat?
So it's short. Long head biceps. Okay, so let's go back and see if we, and what I did to kind of bring that up is I just gave her a little compaction there. That's better. But let's see here. Let's see if we can. Right. There we go. Stretch. Now, that's strong. So I could have her do the 10 things again, but I think that's good. What I want to do is I want to unpack. So laying back for me. So that when you know, like you had a pretty good injury there, still trying to recover. I go right into the joint and I traction it out, and I just find that the humeral head's happy place, and I just move it around until I feel that joint just get kind of nice, and there we go. Loose. So we're going to jam it again. That's better. That's better. So hold there. And let's check that. At those two. Good. And serratus. Good. Infra. And do something. We didn't do something. Yeah, but it's good too. And deltoid. Yeah, deltoid. And then hold. Okay. So that's compaction. Now, if it would have been shearing, i.e. trying to strain, let's say her deltoid, the primary muscle that was involved, it would respond to spindle up, possibly, maybe GTO right about here, and maybe O and I right about here. Of course, it has a broad origin, very specific insertion. And then I would treat, if it was a deltoid muscle that might be antagonist to the delt, could be the pec, especially the pec sternal, which is good, but we give it a stretch like that, and it will be stretch there, and yeah, so she does have that. Okay, so that would be the antagonist. The synergist then would be, what would be a synergist to the deltoid? Well, upper trap is kind of, and of course, supraspinatus is, and infraspinatus to some degree. They all kind of help with that. So the way you, now the upper trap, you had a strong upper trap. Good. And now hold it for about 6 seconds. Relax. Back in again, and stay strong. So that would often weaken if it was a synergist. So that's the triad of strain. So let's do cranials. I want you to screen for let's do a couple things. Hair up, find a weak muscle, have them breathe in, see if it strengthens. If it doesn't, have them breathe in more. See if it's right. And then if it does, then go to a strong indicator muscle and test and see if it weakens on outward. want you to do, just play with that. Now, if it takes a full breath and more, that's a spheno-basal, and we have one that we found here earlier that we haven't fixed yet. You want me to do one first and see?
Because that was one of the first ones.
We didn't do spheno, that's right. That's one we did. So we have gloves.
Right here.
So, thank you.
Whoops, now that I dirtied that.
Use the top one.
Large. So, let's have you, we had you standing, we'll go ahead and lay you back. You guys can come down and yeah, now, I can use any of them, but let's start with these, just in case. Those are not weak. Now, close your eyes. Open your eyes. Bite down. And open it. Go through. This is just a screen for the eyes that draw right. This screen. There's not much there that's obvious right now. Okay. So I want you to breathe in, hold the breath, breathe out, hold the breath out. Wow, right. Now breathe in more. As much as you can all the way there. Good. Now breathe out all the way. And then force it to exhale. That's a spheno-basal. Now, which side is it on? Here. You weaken on expiration. Strong muscle weaken on it. Now go to the other side. Correct. So I'm having you touch where our contact point is. I see it as not what we need. Okay, breathe out. So he's a tough customer. He's a tough customer because he's really good at recruiting. He's very strong. He's got a whole lifetime of you being able to maximize his home. That's just way well. I think. Could be worse. You could be just. You're more like. Okay, so I'm going to go ahead and I'm going to put my finger right on his cruciate. Know that. Now breathe in. Breathe in. So I'm going to do his cruciate first, the one I did on all you guys last time, just because I think it needs to be unlocked. And then we're going to do a spheno-basal. And open. Breathe in. You ever have braces when you're young? Oh, good. Got a nice wide out. So you start in the middle for a breath or two. Then you go back to the back part of the suture. Just work your way. I'll make sure that doesn't. Now touch your mask. Doing a two-handed. Yeah, one of the hands is on it. There it is. That's when you touch over here. Just right there. But it's on the left. Speed away. Hold the breath. And it's negated by the. So the way I treat it is going to be, this hand is behind his mask way.
this hand is on his, right on his midline. Now, in the book, it talks about pressing off to the right. If you do that, I think it's more effective to press more midline with a little bit of off to the right vector. You want to put pressure through that vertical plate that you're pushing through the heart palate into that plate, and the plate is pushing in the speed. Because you're not directly pressing in the speed. You've got to use that. If you're too far over this way, you're not going to direct the force into that. Now, somebody will probably argue with me on that at some point. Breathe in again. There we go. These are very rewarding. First couple of, if you guys want to come closer, it's fine. I'm going to do about 4 or 5 more of these. The first few, I'm really letting my fingers kind of ride along with this. Then by the third or fourth, starting to, give a little more. Kind of this way. Couple more. Breathe in. You'll feel the movement. Okay. Now, you'll see a steeplebasilar at times with the ileocecal valve and with the category 2. So let's just screen for that one. That's kind of settling in. Unhanded. Yeah. That helps. I see the. Dig for it.
We did. We had to dig for it. You found it.
Yeah,
We did.
we had to dig for it. So, dig forward. Kidney forward. See, I've got a glove on too, so that's like that hinders letter 58. But even then, that one's not. So that's more classic. Kidney 4 on the right, letter 58 on the left. That's tender. Yeah, yeah. They should be tender. If it's not tender, maybe you move around until you find a different spot. They're not always that tender.
As much.
And so it was before when we talked. Yeah. I'm going to hold these points. Oh, you move your valve up towards your opposite shoulder while I do this. So dig in there, get a good capture. There you go, and just keep breathing. And close your eyes. You'll feel these areas, they'll start to like wake up. But where does the acupuncture meridian energy travel? It travels in the myofascial matrix. It travels like piezoelectric little waves along the fibers of the myofascial. That's why congestion of the lymph interferes with the chi. Not that, but that. It's like a two-handed TL. You stand again. The thing that we came in on earlier that made me think he had a speedovacular is we had this lap that was strong, but when he fully exhaled, breathe out all the way, and hold. It weakened. It was not. Breathe in. Hold breath.
Breathe out through your nose, all the way, all the way. Is that clear?
Say that categories also, so it's
Category 2 often associated with category 1 with what were you asking? We did, because we were just, here, sit. We didn't, but push in. With 2 hands for category 1, one hand, other hand. Yeah, so I'm not, yeah. Yeah, actually, yeah. So, find a cranial. Find a cranial and fix it before we leave on somebody. Call us over, please. If you think you have one, but not sure.
Oh, yeah. Yeah.